Thanks, Mitch. Okay, so good evening, everyone. Good morning here from Boston. So I'll go right to the case. When this patient came in, he was 28 years old. He complained of headaches, occasional blurring of vision, and according to him, there was significant family history of glaucoma and high eye pressure in other family members. When he presented, his initial exam was his vision was 20/20 in both eyes, high IOPs in the 30s. The anterior segment exam was unremarkable. The gonioscopy open angles, and the disc was non-glaucomatous at that time. So these are just photos of the anterior segment, the angles, and an anterior segment OCT showing an unremarkable exam. So at this point, as when you see these patients in the clinic, you run through a list of possible things, and you might think this is juvenile open angle glaucoma, a pigment dispersion glaucoma, primary congenital glaucoma. Although with primary, with the age, it might be a little late. Although we can see some patients surprisingly with genetic mutations which cause PCG in older patients. It could also be an anterior segment dysgenesis, but as we showed in the photos, this is not the case. We should be able to eliminate steroid-induced glaucoma because this patient does not have any previous ocular history. There's no signs of uveitis, so we could rule that out. And the patient does not claim to have any traumatic events in the eye, so we could also rule out a post-traumatic glaucoma. Okay, so with these symptoms, with these findings, the initial diagnosis of this patient was ocular hypertension on both eyes. The normal diagnostic tests were requested: Humphrey visual fields, anterior segment OCT, and an optic nerve OCT. And rightfully, the patient was managed conservatively with just prostaglandin analog eye drops and beta blocker. And with these two eye drops, the lowest IOP that was obtained was 12 to 15 millimeters mercury on both eyes. So from a clinical standpoint, I think this is going well. We were able to bring the IOP from the 30s down to the low and mid-teens, and so we could send the patient on his way, right? Okay, but patient comes back 2 years later. He claims he was compliant with all the eye drops, with the 2 eye drops that he was given, but upon checking, the IOP was uncontrolled. It was in the 30s again. A third IOP was provided and had minimal effect. The IOP was still in its 20s, and now there are glaucomatous changes, as you see here on the right. So how does this change things? The patient mentioned that he had a significant family history, so I think it would be good to go back to the family and ask him about it. And this is what we found. So this is the proband here in this shaded square, indicating that he's male, and then the circles indicate that the patient is female, and all those with shaded shapes indicate that there is either family history of glaucoma, or it has been told that they have high IOPs. Okay, so you see here multiple generations, 4 generations of patients with glaucoma or high intraocular pressure, and you can see that both females and males are equally affected just by eyeballing it. So this seems like a dominant disease, and we are concerned that this is highly prevalent. This disease is highly prevalent in this family. So at this point, we initially started with a diagnosis of ocular hypertension, and now we're more confident that our diagnosis is juvenile open angle glaucoma. But also, we want to ask, is this the correct diagnosis? And then when we talk to the patients, we ask these questions. What should the patient expect regarding the disease course? Will it will the patient need surgery? Will the vision worsen? These are questions that patients always ask, and I think we should always, so be, as doctors, we should be also prepared to answer them. And then more importantly, which family member should be monitored for glaucoma development? What's the disease risk of disease in current and future family members? And then finally, what's the best treatment strategy? Do we stick with the IOP lowering medications? Do we proceed with laser, or should we proceed right away to surgery? So these are questions that we need answers to, and I think to summarize, these findings. So far, we have a clinical diagnosis of ocular hypertension, and now we're more confident about our clinical diagnosis, which is juvenile open-angle glaucoma. Glaucoma management, as we mentioned, there is failure of medical therapy, and so we have these options: either a trabeculectomy, an ab interval trabeculotomy, or GAT, or a tube shunt. And then finally, from the ocular genetic standpoint, we want to establish a genetic diagnosis. We want to do this so that we are able to approach this patient and their family better. So why do we need to do an ocular genetics referral? We need this to be able to request the appropriate genetic investigation, interpret the test accurately, as Dr. Ibanez mentioned in his talk, and then help implement a personalized care pathway, which, if we don't know the exact genetic cause, then we won't be able to do this. Okay, so as in genetic testing, we always ask, why do we have to do this? Why would we want to do this? I think it's important to underscore the clinical utility of genetic testing. So we want to do this so that we can provide an accurate diagnosis, enable appropriate counseling to the patient and the family members. It definitely helps guide management, and as also Dr. Ibanez mentioned, it will help determine eligibility for future gene-based therapies, which we are all very excited about. And just to underscore the fact that we need to do genetic testing in these patients, here's a pie chart of all the known genes. We just know of 10 genes which cause early onset glaucoma, which means there's glaucoma before the age of 40. And we just know of 10 genes which currently, and this explains 20% of all the cases. So 80% of the time, we don't know what gene is causing the disease. And so this gives us, lots of leeway to find discoveries, to determine the molecular pathophysiology of the disease in patients with these conditions. So in the Philippines, I always get asked, how do we do this? So I think I'll just simplify it. First, the patient does come in, as what happened in this patient. The patient comes in for a clinical exam. The family is ascertained, and the pedigree is established. It's not, at this point, it's not really important to get samples from all the family members. Just the proband or the main patient is enough. So it's either we get the DNA from saliva or whole blood, send that to a reputable laboratory. Now, currently, there are some laboratories here in the US which have very low cost to do genetic testing, as low as $600, $700. So you can send those over. Again, we're here as ocular geneticists, or we're here to help you select the appropriate genetic test. So for this patient, a gene panel test by screening known genes, the 10 genes, was done. Then are we able to identify the disease-causing mutation? If it's a yes, so we discuss this with the referring clinician, provide counseling, and institute a personalized care plan. And then cascade testing for family members, which means just gathering other family members who might be interested and who also have symptoms, to do testing. We don't have to do the whole panel test. We could just do Sanger sequencing, which is much cheaper. And then important is to refer to the appropriate patient support group. And there are some in the Philippines in which you can reach out to me if you have questions about those. If we don't find any disease-causing mutation, then we discuss this also with the referring clinician. We provide counseling and monitor disease progression in these patients just to watch out for any other symptoms. There's not much that we can do at this point since we don't have the disease-causing mutation identified. As a service, we can try to help patients by scanning literature regularly for new variants or genes with similar phenotypes. And then I would advocate for referring to appropriate research studies for eligibility. So back to the case, the gene panel test for this patient revealed no disease-causing mutations in the known early onset glaucoma genes. So we have to discuss the implications of this negative finding with the referring doctor and the patient. And then we want to examine also other family members, both infected and unaffected, just to establish the disease. And lastly, we want to invite the patient for research in a research study to identify novel genes and mutations. And so fortunately for these patients, there is a current study which I'm part of, the genetic etiologies of early onset glaucoma in the Philippines, where we do whole exome and whole genome sequencing of unsolved cases. We want to better represent Asians, Filipinos in genetic studies, since 70% of genetic studies involve people of European and Caucasian descent. So there's a big discrepancy with regards to representation. All eligible Filipinos are invited to participate, and there's no out-of-pocket cost for study participants. So for this patient, they were part of the bigger study, and what we identified was a novel genetic variants in they were part of this patient was part of 3 unrelated Filipino families with JOAG. And the mutations, since this is a big family, it was very easy to identify that the mutation was segregating, and the mutation is the likely cause of that severe JOAG phenotype. Experimentally in the lab, I showed that the EFMP1 protein was retained in the endoplasmic reticulum, and this could be detrimental to the patient's eyes. And this is the report. Very important is this is the report of EFMP1 mutations causing JOAG. And then just some illustrative examples. So this is the EFMP1 wild type protein. You can see how in magenta, you can see how well distributed it is inside the cell. And these are the 3 mutations that were identified. For this patient, it was the EFMP1 N80Y mutation, showing a aggregation of the EFMP1 protein around the nucleus, which is where the endoplasmic reticulum is. And then just a Western blot showing retention of the protein, and this is the densitometry analysis of the Western blot showing these 3 mutations in EFMP1 causing intracellular retention of the protein. So this brings us a step closer towards precision medicine. And what are the recommendations for these patients? For this patient, if you have the EFMP1 mutation, you have high IOP, and you have optic nerve disease, you should be treated right away. Do it aggressively, because we could see in other family members, they do not do well on just medical treatment. And so we should opt right away for the most aggressive treatment available, which in this case should be surgery. If the patient has an EFMP1 mutation, there's normal IOP and normal looking optic nerves, we advise close surveillance as frequently as 3 months follow-up or 6 months. This allows us for targeted surveillance of at-risk family members. And then finally, for those without the EFMP1 mutation, we can tell them that they are not at risk of developing JOAG seen in their family members. And so this actually prevents unnecessary exams and anxiety in non-mutation carriers. So this helps them a lot. And then so finally, as a summary, we discussed why establishing the genetic cause of a disease is important. It allows for a more precise diagnosis, allows us to properly counsel patients and families. It helps guide management and follow-up, as I showed in the previous slide. And then there are preclinical tests, preclinical gene-based therapies that have been showing up in literature. So we want to be able to contact them, these patients, for future gene-based therapies once they become available. And then I also advocate for genetic testing for patients who you see in the clinic, if if they fit the proper criteria for genetic testing. And then we also discussed how 80% of cases in early onset glaucoma have an unknown genetic cause. And in the last part of my talk, I described the EFMP1 mutations causing JOAG in 3 unrelated Filipino families, expanding the list of genes that we should screen for when we see patients with JOAG. And finally, the genetic diagnosis allows for more precise management of the disease. And with that, I'd like to thank all these people who've been instrumental in my work. And if you have questions, you can email me at this email address. Thank you.